Hi, my name is Jamie Platz, and I am a student, X-ray student at El Centro College, and I am going to be discussing an image that I took of a 27-year-old male who was presented in the outpatient department for a follow-up X-ray post-surgery. So this gentleman was in a motorcycle accident and had surgery, and he comes into outpatient to get his follow-up x-rays just to kind of evaluate his progress. So this is my image here, and we're going to be discussing how my image was, although it was a suboptimal image, it also still was able to give the radiologist enough information to distinguish his progress. So, after examining his, the radiologist examining the X-ray, he was able to tell the findings showed a superior displacement of his patella. There were no fracture lines identified. He also noticed some heterogeneous sclerotic changes. Also, his infrapatellar soft tissue showed heterogeneous calcifications. I know it's kind of hard to tell, but you can actually see right here. You can see my TV in the screen. Let me go and turn that off. You can see here this white speck in the posterior aspect. That's actually calcification there. And in his patella, although it was his knee was angled at a 20-degree, it should have brought his patella a little further down and made it more anterior to this condyle. But because of his injury, what had happened was there was his patella superiorly displaced due to his injury. And you can actually, I know it's hard to see with these lines, but he has some calcification down here on this ligament. And so basically the calcification builds up due to tendon injury. That's the probable cause of why he has this calcification buildup here. So the projection that I did was a medial lateral knee projection. It was obtained with him on the x-ray table. Patient was in the recumbent position and right lateral, and of course the beam coming in medial lateral. Now I made sure to center my CR 1 inch distal to his medial condyle. And then of course I manipulated his body to ensure to place his femoral epicondyles perpendicular to the IR to ensure to align the anterior and posterior margins of the medial and lateral femoral condyles, as well as aligning the tibia to superimpose the fibula by at least 1/2. Now, if you notice, now what you're supposed to do on a lateral knee and where I was doing my clinicals at, it's mandatory to put a 5-degree cephalic angle on all of, for the AP projection as well as the lateral. Now, if you see here, the posterior and the anterior portions, the condyles are pretty much aligned, as you can see here. But what the issue here is the medial condyle, which sits more distal, and it's quite larger than the lateral. Wait, right? It's larger and it sits more distal to the medial. And so you put the cephalic angle to bring up the medial condyle, and so you can actually superimpose the medial and the lateral condyle distal portion and bring them to where they're superimposed, which then opens up your knee joint. Well, for me, I forgot to put the angle on the tube, so I was able to position my condyles anterior and posterior, but since I forgot to put the angle, it closed up that joint space, which you can see there. So I feel like when I shot the image, I did use an AEC, and the technique it gave me put my EI range, EI number within range. So you're actually able to see some pretty good contrast, which was able to show, you know, it's hard to see on this tablet, but the calcifications and the different gray scales to kind of determine the radiologist diagnosis. So as you can see here in my image, the distal and medial and lateral femoral condyles are not superimposed, which the distal portions does not make it an optimal image. And, you know, again, I should have put the 5-degree cephalic angle on the tube. And then another error notice was here, the tibia is supposed to superimpose the fibular head by at least half is supposed to be superimposed, and that did not occur here. Now, of course, this could be anatomy and due to injury that happened here at the knee. What I didn't do, and Martinson suggests, is you know, not only have put the 5-degree cephalic angle, which might have helped to superimpose my fibular head. I could have also angled my CR 30 degrees to the long axis of the femur. So just kind of turning the tube might have also assisted in creating that required criteria. But overall, I feel like my image was an acceptable image, and we can just kind of discuss the different anatomy here. And of course, we have the right femur shaft, which is here. And then the patellofemoral joint space between the patella and the femur, which is right between there. And that space is nice and open, like it's supposed to be. Now we do have the femorotibial space, which is here, and of course that space is supposed to be open, but the medial condyle was not brought up by the 5-degree cephalic angle that I did not put on the tube, so it did actually close up the joint space. We can see here we have the tibia tuberosity, which is here, which is on the anterior portion of the tibia, and of course this is our tibia shaft. We do have the fibula, and then of course the fibular head, which is here. We can also notice here, back here, that's our lateral condyle, and of course the one that's closing up the space is our medial condyle. And I also made a notation of the calcification, which you can actually see this very large one here in the posterior aspect. The white area, anterior and posterior, showing calcifications. And it's really hard to tell because the lines are coming through, but you can actually see the tendon that stretches from the patella to the tibia. There's calcification there, and they're just very faint white specks. So that is my image, and I hope that you all enjoyed my video. I used my marker as well. Always a plus, isn't it? All right. Well, I hope you enjoyed my video. Thanks, guys.